Then we are talking about PID, then ectopic pregnancy, pelvic pain, reactive arthritis, and then the perinatal conjunctivitis and pneumonia could be there. When we are talking about gonorrhea, usually we give the ceftriaxone, but here in the thing that we give cefixime. But yeah, single dose of ceftriaxone. They keep on saying the single dose because the single dose we give in the clinic right away in front of us. Okay. If pregnant, above regime or the spectinomycin plus the azithromycin also treat the chlamydia, treat partners reportable disease screening as with the chlamydia. So same work for whatever both of them. Now we are talking about human papilloma virus. So for your understanding, you need to understand wherever the HPV is there. Okay. So in these cases, you have to do the if you keep this thing in your head, HPV is readily transmittable. How do they transmit? In those cases, we go for the pap test. It will help you to understand in which cases you have to go for the pap test. Okay. So this is basically the one that is 6 and 11. They do cause condylometalata. But the one that is higher number 16 and 18, they are the cancerous one. So 16, 18, 31, they are the one that causes the cancer. So for your understanding, think of the lower one does not cause anything. The higher you are, the higher chances of cancer it is. Now, HPV is easily transmittable between opposite and same-sex partners through receptive and penetrative, through vagina, oral, and anal and non-penetrative sex. So now, if a scenario can come, a female, she has a female partner. Okay, female with female. Are we going to do a pap test for both of them or not? So in that case, is yes, we do the pap test for them even though she has a female partner that does not work. So they says the same sex partners through receptive or penetrative, whatever it is, you have to go for the pap test. And it's a very common question. They do like to ask for the pap test here and there. If you don't know how it's got transmitted in those cases, we don't understand it. So HPV is easily transmittable. So in those cases, even it's a opposite sex or same sex, so in those cases, we go for the pap test. Infection with one type of HPV does not appear to provide protection against the infection. So recently, a female sorry, not female, a male got exposed to HIV. Okay, and then he came to get prophylaxis for HIV. Like he thinks that he got involved. In that cases, what I did was like what our job is as a family physician, you have to give the prophylaxis for HIV and he is asking now his question is because it can be asked in the exam scenario too. So his question was how long this protection will work for me. So what I told him is that this time he got involved, so we are giving him the treatment, and then once he finished this treatment, the one he got exposed this time, he will be getting the prevention from that one. But if in the future he got exposed again, then he needs the protection again. So you get my point. In that cases, you have to be very smart and see what they are coming from. So these kind of questions can be asked in this ethics point of view. Like HIV can be tested in this way that she got exposure. What are you going to do? So first of all, offering them a prophylaxis, PEP, those ones, then giving it for how many days? So usually we give it for 1 month. And after that, for how long does the protections last for? Usually until he gets exposed with the next thing. And how do you counsel that person? So usually offering them to use a protective sex like using condoms. So these are some things that can be asked how you are going to do next, what are you going to counsel that, or what you're going to offer. So this is how the HIV test or question can be asked when just we are talking about this one. That's why I'm saying. Then another question can come from HPV is basically asking about Gardasil. These days, people are asking about Gardasil a lot too. So if a female or male is coming to you for the Gardasil and they have gotten or they are not sure that they get the treatment here vaccine here in the Canada, usually if they are going to school or did this can attended the school uh, in uh, in Canada, they do get the Gardasil immunization in their schools. But if let's suppose somebody did not get the high school from here or schools from here, so in that cases, if they are not sexually active, then offering them is a good choice. But if they're sexually active, then even though you offer them, it's not gonna be helpful. So you can offer them, but at the same time letting them know that they are already sexually active. So Gardasil or whatever is not going to give them enough protection because they are already exposed with it. Okay. So in that cases, you have to see what you are saying. So it can be asked in the exam. Then the clinical features, no visible lesions are there, subclinical infection, then checking for the colonoscopy, visible wart and hyperkeratotic. So usually please see how does the condylomata lata and condylomata acuminata looks like. Then you are going to do the pap test, usually the pap test in the male. I don't know what is the test for male. We haven't done any, but usually the colposcopy and the pap test is for females. The detection of HPV DNA subtypes, usually in the nucleic acid probes, that cannot be routinely done, so it's very less likely. Anogenital warts. Now, this is something. That's why I said you need to know how does that condylomata and lata or acuminata looks like. So now when an anogenital wart is presented, how you are going to do a treatment. So recently I saw a female, she is not sexually active, but she has anogenital warts and she wants to get the treatment for that. So in that one, she wants to go the treatment by herself and she also wants to get a referral for dermatologist too. So if you can see in this one, the provider treatment, usually it's done by a dermatologist. I mean, you can do that too, but the genital parts are very sensitive, and especially for females, they do like to get some specialist one. So cryotherapy, podophyllin resins, and TCA is the one for the provider ones, or the razor removal. But when it comes to the patient one, what are the names specifically for the patient administer? Like they can do or use it at home, or they can ask you what are the treatment for at home, or she wants to use something at home. So the names are different. What are those ones? Podophylox, imicumod, or syncatechins. So what we practice is imicumod, and then podophylox usually works really well. But imicumod is not covered by the like your insurance. Still, if you want to go for at home, so this is the imicumod is the one. But then the provider one is basically TCAs and podophyllin. Then the treatment is Gardasil, Cervarix, condoms may not be fully protected, but in the end of the day, these are the vaccines. And if they get sexually active, it's not going to work them. But still, if they want it, then why not? Then comes the HSV, maybe asymptomatic initial symptoms, prodromal symptoms. What are the tingling, burning? Then multiple partners could be there. Inguinal lymphadenopathy, dysuria, urinary retention, recurrent infection. What do we do is basically going for the viral culture, HSV DNA PCR, then the cytological smear, and then going for serology test for antibodies, HS1B, and those one. This is basically expensive and we don't do in Canada. Then treatment is acyclovir, just for your knowledge. Then recurrent treatment is acyclovir again and going for over and over again. In the severe cases, we go for IV. Then in the education point of view, you have to ask them to avoid sexual contact from that one until the lesions has been resolved. Now comes the syphilis. Syphilis is something like if it shows up one time in your blood, it will stay. So in that cases, we do have to do the screening, checking for the titers, how much they are. So HSV, sorry, here. Primary syphilis, secondary syphilis, latent syphilis. Primary is 3 to 4 weeks after exposure. Secondary is 2 to 6 months after the exposure. And then the syphilis, there is no specific treatment. Now, I was talking about the condylomata lata. This is basically in the syphilis point of view. And then this is basically painless, all of that. So usually you have to see those one. Serology test must usually be positive. Now, tertiary syphilis is where they involve the other organs like cerebral, neurological, all of those. Congenital syphilis is basically, with the congenitals, like the newborns. Then investigation is going for the aspiration of the ulcer serum. Dark field microscopy, look for the spirochetes. It will always be positive. Once the syphilis is there, it's there. Then comes the VDR and PRP is non-reactive of the treatment, can be positive with other conditions as well. So usually this is not the screening one. Then comes what is the screening one? So confirmatory tests remain reactive for the life even after the adequate treatment. What are those ones? FTA, AMS, MHA. These ones are the specific ones. So they say non-reactive after the treatment, but it stays there. Okay. So in that one, FTA, this and these ones, the antimicrobial antibodies, these are the tests that we usually do for the specific one, checking for that one. So The most specific and sensitive one that you need to understand is the dark field microscopy. Then comes the non-treponable screening ones and then the specific ones. The screening one is there, can be positive with other conditions too. And then the specific one is there, this one, this one, this one. And this says the confirmatory remains reactive for the life. So there isn't anything usually to confirm whatever. In those cases, we check for the titers. Okay. That is the one that helps with the understanding of the finding of how much is there and they are active. Then comes the treatment. Reportable disease partners should be referred for the treatment. Primary is basically now you cannot write down the penicillin. You have to write down the benzathine penicillin. The answer is benzathine penicillin. Maybe in your MCQs they can give you. Now, when they're talking about the neurosyphilis, it's not the benzathine penicillin, it's the aqueous penicillin. I mean, we do make a lot of mistakes with this one. Then this can be given in the scenario. So this one is basically the neurosyphilis is basically aqueous penicillin. Then comes the screening. Screening is basically how you check for the screening in high risk people. Then the HIV or sexually transmitted, history of the incarceration in pregnancy, you have to check for the syphilis. We do check for the screening. If untreated, then 25 to 40% of the cases. So the answer, the investigation is very, very important. Please give it a quick read and then do understand what they're trying to ask. If they're asking about what is the most sensitive and specific diagnostic test, this is basically dark field microscopy. And many answers they are asking about is dark field microscopy because the other not the other one is non-reactive ones. So you have to see in those ones, you have to say that this is non-reactive. So it will stay, or it can be asked, okay, so the VDRL positive or PRP is positive. What will you do in that case? Or how will you deal with that case? Or is it, if the PRP is positive, patient is asking you if she is having syphilis, in that cases you have to say no because it can be positive with other conditions too. So this can be asked in many ways. So here from the Bartholian abscesses, basically they can ask you a patient is having a lesion in her genital area, which makes her uncomfortable to walk. Simple, uncomfortable in walking. Okay, so that's why she's coming. In that case, we go for incision and drainage. Then comes the pelvic inflammatory disease. The pelvic inflammatory disease is very common with the infertility. So in that cases, usually female presents with infertility and now coming for the this one. So here is one thing that obviously the clinical features nausea, vomiting, dysuria, pain, dyspareunia, palpable mass or whatever it is. Then checking for the beta HCG, urine mass, then checking for the vaginal swab, NAT, HIV. So you have to rule out everything that we have already done so far. Then the ultrasound, you have to check for the cul-de-sac, free fluid or ovarian abscess, hydrosalpinx, laparoscopy. Now comes to the treatment. Now, the most important treatment is when are you going to keep the patient in outpatient treatment or inpatient treatment? And again, in which cases you have to remove the IUD and in which cases what are you going to do next? So must be a microbial coverage, percutaneous drainage of the abscess if there is any ultrasound, done. And then the laparoscopy and then usually the incision and drainage done in ultrasound guided. So consider removing the IUD after minimum of 24 hours of the treatment. So don't remove the IUD right away after confirming that this patient has PID. Very, 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 very important. Okay. So it can be asked a female is having IUD. She is now having abscess. In that cases, what will you do? So usually we start thinking, oh, IUD is causing it. So in that cases, we remove the IUD first. No, you have to do the incision percutaneous drainage. Then in that one, next going for the antimicrobial, then treating for 24 hours, then removing IUD. It's very important, or they can ask you when will you remove the IUD. So it's after 24 hours. Okay. It's a reportable disease. Treat the partners, chlamydia and gonorrhea 4 to 6 weeks after the treatment if documented. So you can see when are you going to the inpatient and when are you going to do the outpatient. Usually the patients who are stable, we do outpatient. So stable, they can tolerate the medicine, everything, follow up in 28 to 48 hours, whatever it is. Ceftriaxone, doxycycline is the one that we do the coverage. In inpatient where they are not tolerating, it's a first time and she's pregnant, immunocompromised, in all of those cases. What are those ones? The complication, the pain, hydrosalpinx. I recently saw a case where she was having a hydrosalpinx. And I told her when we can start the antibiotics, and then a female can directly present with hydrosalpinx, no PID, nothing at all. So in that cases, you can offer the antibiotics as well. If she's not having too much pain, you can watch and see. But she was not having too much pain and she does not want to take any antibiotics. In that case, we are going to follow up again in 3 months for her hydrosalpinx. Abscess, peritonitis, adhesions, ectopic pregnancy, infertility, bacteremia. So then basis of where the pain is, according to that, the treatment or sorry, the diagnosis will be different. Then the toxic shock syndrome is common because of the tampon use. So like they are having, or even the IUD is there, and that can cause the toxic shock syndrome. So treatment of the shock, that's how it works, and the checking for the infection. So sexual dysfunction comes along uh, with infertility. So you have to, whenever you're reading the sexual dysfunction, consider the infertility as well in your mind. So in the lack of desire, arousal, and then anorgasmia. So the thing here is when it comes to the female one, they are having a vaginismus. It's very important to understand the diagnosis of vaginismus and how you're going to treat the vaginismus. So you can see there is pain, intracoital, vaginal, and then deep. So if there is an intracoital one, it's an adequate lubrication. In those cases, providing that one, then when it's vaginismus, so it can be given in a scenario where she's having pain during intercourse, and now she's coming to you. She always complain of this, and she tells you what is going on. So that what is your diagnosis? Okay, so the answer is vaginismus. And now, another one, if a female is coming and she's in 60s. I mean, I recently saw she was 28 and she was having this, she feels like that her during intercourse, she feels that it's not comfortable and she thinks that it's dry. So in that case, is providing the or inadequate lubrication. So what's your diagnosis? So it's an inadequate lubrication. So the diagnoses are different. Please keep it in your head that what is the diagnosis and what will the presentation is. So vaginismus is different and then lubrication point of view is different. Then the Bartholian gland infection, lichen sclerosis, I keep on telling you, please see the difference of lichen sclerosis and lichen planus. Planus, the word is planus. Then the vulvovaginitis, that could be the chlamydia and infection. Then the midvaginal, mainly the infection is there. Then the deep is mainly endometriosis, adenomyosis, leiomyoma, abscess, all of those ones. Then the treatment. Usually we starts with the patient goal, safety, counseling, lifestyle, body change, lack of desire. In those cases, checking for the conditions, checking for all of your hormones, physiological treatment, and then the relationship with the partners, and then the biological treatment, the lubricants, estrogen creams, those ones, and then physiological. So I ended up finding out that she who was having this lubricant problem, she was having a candida infection. That's why she was feeling. So what was happening to her? She was having the lubricant issue, and then she started using something where she disturbed her vaginal flora and then ended up getting the yeast infection. So once the yeast infection was being treated, she was getting back to normal. So you have to see what's going on along with that too. Then physiological relationship point of view. So usually offering them the Viagra. Now a patient is coming up to you asking about Viagra. So I don't think so in the Toronto notes they have given anything about the Viagra side effect. Please kindly see where else the Viagra were. So Viagra do affects the high blood pressure as well. So it has a little bit of effect on the heart. So people who are having heart conditions, you have to see if you can give them Viagra or not. Okay. So please keep that in your head. Biological is augmentation, then sex education, relationship with stimulation, then biological use of estrogen creams and nerve stimulation, then sex therapy, and rule out the abuse. So whatever is going on, so you have to check for that one. Then comes the menopause. In menopause, usually you have to check for the contraceptives, which contraceptives will or hormonal contraceptives will work for them. So there's vasomotor, urogenital, skeletal, and then soft tissue psychological. So what you need to do is here, this table, it's important. Now we are talking about the treatment. I mean, you can read all of that. It's important. Go for whatever it is. But the main is basically no treatment. It's just the perimenopause and then the menopause. In the treatment, then when we are talking about the vasomotor instability, in that case, is starting with obviously for any kind of menopause treatment, the first line is menopause hormone, many of them, in many cases. The answer is menopause hormonal treatment, MHTs. But then again, you can see SSRIs, venlafaxine, gabapentin usually work in atrophies, the local vaginal cream, like the estrogen cream, then the suppository and all of that. Then the urogenital health, lifestyle, bladder, and then again going for the local estrogen replacement therapy, osteoporosis, check for calcium, vitamin D, smoking cessation, bisphosphonates, and then going for HRTs. So then decreased libido, lubricants, counseling, CVD, checking for the CVD factors, and then for the mood and severity is the antidepressant. So if they are having hot flashes, check telling them about their daily lifestyle modification. Then what are those ones? The side effects and the benefits. The benefits is having the reduction of all of those side effects which they were having, like vasomotor, sleep, mood, X, prevention, vulvar. Now coming to the risk factors. So we already, if you could recall, the estrogen, progesterone, wherever they affect the thromboembolic events, stroke, breast cancer, coronary artery disease, sorry, heart disease, endometrial hyperplasia, and cancer. I will tell you about endometrial hyperplasia and cancer. There is little bit you need to remember from there. Then those are the things that we usually use. Moderate to severe hot flashes or the night sweats, no. Then in those cases, going for the genitourinary symptoms. Any dryness is there? If yes, then we are going for the lubricants. But at the same time, if there is nothing, then avoid the hormonal contraceptives, checking for if lubricants work for them, going for those. If not, then going for different options. Yes, if there is any hot flashes, then checking for the breast cancer and the endometrial cancer, ruling out all the contraceptive contraindications. Then if no, then free from contraindications to SSRIs and SNRIs, then going for SSRIs and SNRIs and considering that one. If there is hot flashes, adequate control of hot flashes, yes, then continue with that. If not, then going for the other options. If there is any problem or any contraindication present, then going for hysterectomy. In cases where CVD, like heart condition, now a straightforward scenario comes to you where they are or given to you, where they're giving a heart condition, where they says there is a since menopause, he or she is having a high risk of contraceptive. In those cases, choose the transdermal one. If there is a high risk, avoid. In all cases, you have to avoid that. Even if the low risk and there is a high year, since the menopause is more than 10 years and there is low risk of cardiovascular, you have to avoid the hormonal contraceptive. So please keep it in your head. The more you are having the years of menopause, even the less risk of CVD, we do avoid the hormonal contraceptives. Okay. So this is very, very important in which cases or in which cancer chances where there is a heart case diseases, which one you are going for hormonal contraceptives. Okay. Then the side effects and moods, we already know the estrogen and the progesterone, it causes the weight gain, bloating, these ones. What are the contraindications? The absolute one, at least remember the absolute ones. The liver, vaginal, breast, uterine and breast, both vascular and then cardiovascular disease. Then the prolapse one, usually in the prolapse, if they're pelvic organ prolapse, the treatment is weight loss, pelvic floor exercises, Kegel exercise. Many answers just ended up Kegel exercises. Then the local vaginal cream and then the vaginal pessary. So you can see which one is the which features. So if there is an anterior, what happens in the front? There is the present the bladder and then urinary tract. So that came out. So they will have the problem with the urine. So you have to do the conservative treatment and colporaphy. Now, if there is a posterior one, what is present in the posterior? The anal wall. So they will have constipation or stool in that one, giving the conservative treatment or the laxatives in the stool and the posterior colporaphy. Then comes the uterine prolapse, and that one is what happened, atypical prolapse, groin, back pain. So the prolapse, like the uterus is coming out. So then in that case, he's going for the hysterectomy or whatever the conservative treatment you can go. Then the wall prolapse, only the vagina is coming out. So in that case, is going for the sacrocolpopexy. Uh, in the stress incontinence, in the urine continence, all you need to remember is like how to make the diagnosis. Now again, how to, like, there is a table, I think, I don't know where it is, it's here or in the different table, in somewhere there is a table. All you need to remember that table, that will help you a lot. For me, how I remember, for stress, obviously we have an idea how stress works, where sneezing, obesity, or whatever the chronic cough is there, that causes the loss of urine, right? So that is basically the one. But in the start of any incontinence, please, 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 if they're asking about what you are going to start with, rule out the UTI, urine dipstick test. Okay. Once the UTI is ruled out, now go for any kind of treatment. Even if they say the cough is causing the leakage of the urine and all of that. Okay. So you have to start with them. Now, how do I remember? I remember that the stress one, there is only surgeries. Okay, for your understanding, you can remember the stress, the treatment is surgery. Okay, so you can see the treatment is for conservative management. Obviously, the Kegel exercises, weight loss, whatever those ones. After that, the vaginal pessary. So then we are going for the, what is that one surgery? The mid urethral link sling, urethropexy, pubovaginal sling, and then urethral bulky. Now, when it comes to the overactive, this is mainly because of any kind of underlying disease, like diabetes could be there, heart failure could be there, diuretics the patient is taking. It's mainly in the old female. Usually, in the stress one, they will give you an idea about, oh, she has a 5, 6, deliveries, or she had a previous surgery, hysterectomy, or anything like that, where they will give you an idea what it was, like, being explored before. In overactive, they will give you she's diabetic, she's Parkinson, she's dementia, she's having something, something, something. So that will give you an idea that this is coming to overactive. Like the side risk factors will give you an idea about this one. Then you have to rule out obviously the UTIs, and the answer is they are medications. What are those ones? Oxybutynin, then the mirabegron. Usually, I don't know, recently I've seen so many people taking mirabegron. I have never thought of I will see any case like that. Then again, behavioral modification, then the pelvic physiotherapist, Kegel exercise, and all of those ones, which medication, the oxybutynin, and then the mirabegron, and then the sacral neuromodulation, then the detrusor Botox injection. So for your understanding, if you can just remember the oxybutynin, then the mirabegron is more than enough for you. Now comes the mass. So I told you you don't need to remember many of the, cancers, but again, you need to remember the endometrial cancer. Like you need to at least able to make the diagnosis of endometrial cancer and then cervix cancer. I will let you know what you need to do from here. So from here, you need to do only the risk factors, as you can see from the side. If there is a previous ovarian cancer, breast cancer, colon cancer, obesity, late menopause, diabetes mellitus, nulliparity, unopposed estrogen, HRT, tamoxifen, if they are taking any of this one, this can lead towards the endometrial cancer. Now, a patient comes to you, she is basically having vaginal bleeding. She is 70 or 60 or whatever it is. She is having vaginal bleeding. Okay, and she is gravida zero or whatever, she has never had any periods or any pregnancy before, or and her menses started in the age of 18 years, although she never had this problem before, but she's now having it in now, and she was using oral contraceptives. If you can see, all of the things that I told you is filled in these risk factors. If all of this can be given, in sometimes they just give you a patient with the vaginal bleed and she is never pregnant before. That's it. Now you don't know what is a cervical cancer or it's an endometrial cancer. But if you see, the nulliparity is the one in the risk factors in the endometrial cancer. So you need to remember the risk factors. Or maybe they can give you a 60-year-old female who has never been pregnant. Which cancer is very common in this one? They did not give you that she's having vaginal bleeding or whatever. So they can directly give you a risk factor and ask you which one is common in that one. Okay. Then forget about this one. Then we have to do the, if you have time, you can read this one, the functional tumors of the ovarian. Then we come to the cervix one. Where is the cervix? Yeah, here. So in this one, you also need to remember the risk factors. What are that one? If they have HPV, we already discussed HPV one. Then the multiple partners, one of the most important thing. Then the STIs at the first early age of intercourse and high risk male partners, smoking, immigrants. They do have a lot. Then poor screening update is the most common factor. And then immunocompromised, low socioeconomic status. So a refugee, they can give you a sixth trade worker. So, okay. And then in the cervical cancer, they will say the vaginal bleed and along with some sort of foul smelly discharge. Okay. Although it's not mentioned here, I'm not sure why, but yeah, the vaginal discharge will be something that can give you an idea that there was some sort of cervical cancer is involved. Okay. So just that's it. You have to do something from here. And then there is a Gardasil, whatever the here. So Gardasil vaccination in Cervarix, so you can remember that it can be given from 9 to 45 years age, and this can be given from 9 to 45 years age. Two doses for this one. This one is for 0, 1, and 6 months. Pregnant women and women who are nursing, limited data is there. Okay, so that's what you need to do from the gynecology. Simple.